Welcome back to the Femme FC podcast. I'm really excited for today's guest. We have Vittoria Marin. Vittoria graduated with a first honor degree in physiotherapy at the University of East London. During her studies, she was exposed to different extracurricular courses, of which sport massage therapy, taping, and exercise physiology were the most useful to pursue her career in sport rehabilitation. During her university years, she spent her summers shadowing highly specialized physiotherapists and strength and conditioning coaches in excellent rugby teams in Italy. It gave her the tools to start practicing taping, strapping, pre and post training, and key manual therapy skills. In addition, it was a great exposure to start dealing with professional players, high level medical teams, and their organizations. In April 2019, she started working as a physiotherapist at Isokinetic Medical Group in London, where she is currently providing rehabilitation service to a variety of patients, including professional athletes from different disciplines. Vittoria, I'm so happy to have you on and to get a chance to chat and catch up again. Thanks so much for being here.
Hi, Nicole. Thank you so much. Very, very, very excited to be here with you as well today.
So, Isokinetic Medical Group is obviously a global, world renowned company. Their conference is the pinnacle of sports medicine research and presentations and extra learning every year for everyone. We were just talking before recording about how thousands of people go, but it still feels like a family and like a reunion of friends coming together. And so, can you share a little bit about your role at Isokinetic Medical Group and the type of work you do with the athletes there?
Of course. So I joined, as you said rightly earlier on, I joined as a kinetic in 2019, and I started treating athletes, and my job was mostly obviously clinical. And we have a setup in Isokinetic where we do see lots of patients, and we develop lots of clinical expertise, and we work through different environments to try and guide the rehabilitations as well. So we have access to a pool, we have access to a gym, to a green room, what we call the green room, which is a sport and movement analysis room where we're able to, work on the biomechanics and the proper late stage of rehabilitation of injuries. And then we have the on-field rehabilitation. So our goal is to try and make every patient's recover better than when or how they were feeling just before the injury itself. So my role is primarily as of a clinical physiotherapist. So I work in 3 environments out of the 4. So in the pool, in the gym, and in the green room. So it's quite cool because I guide the patient through the whole process of rehab from the very, very beginning, post-injury or surgery, to towards the later stages of rehab before the return to sport. And recently, in the last couple of years, I started during COVID. I did a master in sport physiotherapist, and that led me to wanted to research a little bit more and make a little bit more of a difference in our field. So I started 2 years ago with a master of research to focus a bit more on the research aspect of what I do as well, which is very exciting. So here I am, physiotherapy clinical and a little bit of research as well, learning how to approach that world as well.
That is really exciting. And so recently, you and a colleague at Isokinetic put together this article and published it about ACL injuries in women's soccer. What led to your interest in doing this, and what led to the creation and publication of this specific article?
So the point of the article was the journal, the magazine is called Science and Sport, and that's an Italian magazine. And they asked us to try and make female ACL injuries as simple and accessible in terms of knowledge as possible, which obviously is not as easy as it sounds. And what we wanted to try and achieve is trying to put together our clinical experience with the majority of research that we have available in female athletes and female football players and sports people in general, and to try and make it accessible to the players themselves as well as to professionals that don't have as much experience in that specific topic. So there are lots of physios and SNCs that may have a lot of, or they may have access to or have to treat lots of female athletes, but they don't know a lot about it because they may not be the topic of interest primarily. So the main reason why we decided to say yes to the writing of this paper was actually just to make it as accessible as possible and try to put together everything we know about it. So that led us to that publication last month. It was just a month and a half ago.
And it is really difficult to take something as complex as ACL injuries in women's football and make it digestible and simple. So, what was your approach going into it? What were the things that you knew you wanted to focus on, and how you went about making something so complex kind of simple and easy to understand?
So, difficult question. So my approach was reviewing the literature. Everyone is saying there is nothing around female athletes. There's nothing around or known about, what's going on with the hormones, what's going on with the different anatomy that we have or we present with, different biomechanics, different way of moving, different culture and environment situations that females are in. So my bigger question and what led me to write the article and kind of like my approach to write it was I need to know everything that is out there. I need to know everything that has been published up to now and try to make sense of that's already out there with what I know and what I see every day. So that was my approach. So what I did was a literature review as part of my master of research actually, and then try to put that together to make that divulgative article with my clinical experience. And so a lot of the time, for example, I had my athletes asking me, Vicky, I had an ACL injury and now I'm afraid of having another injury because I know that female ACL are a very, very common injury and we are at more risk of injury than males are. Why is that? And I'm just like, how do you know? Where do you read that? How can you know that we are more risk of injury? How is that leading to the fear of re-injury that you have now? And, that kind of like finding myself in that difficult situation of having to answer that question without having a definite research or evidence proof was very difficult, was very hard. And so I was like, let's try to make it simple and see what we actually know about it and what we see every day. So that was my approach to write that up.
And so, did you go into it thinking, like, okay, the main thing I want to share with everyone is that these are the mechanisms, or this is why female athletes are more likely to increase or have an increased risk of ACL injuries? What was like the main point or main couple of points that you wanted people to take from the article?
Um, so the main points I wanted people to know that are that we are different for many things. We differ from males. We differ on how we deal with loading, how we move, how our hormones respond. We don't know how yet in certain things, but we are different. So the main thing was making the world know that females are in reality different than males are, even if we don't know specifically how and why, but letting them know, or letting everyone know was for me very, very, very important. So I think that was the main thing that guided me is like letting everyone know that we're not the same. And also I will add that we know that the majority of ACL injuries in females are no contact ACL injuries. So theoretically speaking, especially for me that I'm working on rehab and injury prevention, especially for me, I feel we can do something to prevent some of them. And so for me, it was very important to, let my athlete know that actually, even if, yes, we could be more prone to injuries, then we could also do something that hasn't been done before to change that and to actually decrease the risk as much as possible.
Yeah, that's a good point, that knowing at least some of the contributing factors that may lead to an ACL injury can help us then determine, okay, how do we help reduce that risk then? If we can take one or two of those contributing factors out of the equation, maybe that reduces the risk of ACL injuries and the high rate of ACL injuries we see in women's soccer players and female athletes in general. So when you're going through the lit review process initially, and like you said, like everyone talks about, oh, there's such a big research gap. And that's true, there is. And it's also true that there is some research out there. And so when you're going through the lit review, what were some of the main takeaways that you were getting from that in terms of differences in ACL injury risk between men and women or female and male athletes, and some of what the research shows might be contributing to that?
So I'm gonna start with something that we know the most and then just like work my way down on something that we don't know at all yet or very little about. I think I will start with the anatomy. So we know that we are made differently because we need to accommodate, pregnancy. So our Q angle is um, larger or greater than the male school Q angle, which leads to a higher risk of valgus or dynamic knee valgus, for example, less glutes activation, and so on. We know that the size of our ACL is smaller because we are built in a smaller way. We are smaller than men are. Our femoral notch is different than the male's femoral notch. We have a tibial inclination angle, which is different. So the anatomy in which we are built is different from males. And we know that. That's been proven. And more research could be done always in everything. But general rule of thumbs, we know that we're made differently. There is some good evidence out there showing also the difference in terms of movement patterns and how we move is different. So, for example, recently Francesco Della Villa and the team in Isokinetic, they shared a really nice article which is called the CAT ACL study, which is the bigger in research when it comes to number of ACLs or number of I would say athletes that are leading to ACL injuries in the evidence in general, where they studied the change of direction as one of the main movements as a predictor of ACL injury. And what they found out is that generally females move completely different way as male do. So they have a less hip flexion, they have a less knee flexion when it comes to change of direction, they have an increased knee valgus, increased trunk tilt, increased contralateral pelvic drop. So the way which we move is a higher risk movement patterning compared to males. So we know that from a biomechanical perspective, we know quite a lot to make an impactful change when it comes to injury prevention. So that's something to be considered because especially as a physio perspective or as a physio itself, we can address that in rehabilitation to prevent secondary injury, but also we can do something in prevention to prevent primary injuries. And then from an hormonal perspective as well, we differ. This is probably the biggest question mark we have at the moment. Everyone is talking about it. It's such a hot and amazing, interesting topic. We know the role of estrogen could lead to increased ligament laxity, maybe. We think there is a correlation at least, and that increased ligament laxity could lead also to a difficulty of the muscles around it to have the control of specific movements, which could lead to a higher or increased risk of strain of the ACL. We know that there is a difference on the cycle length that the female athletes can have. So there's not a normality of their hormonal fluctuations because everyone is different. And we also know the females especially athletes, are more prone of REDs. So having relative energy deficiency, problems with fueling their body properly, the amount of loading they're lifting because they may feel painful or tired due to certain hormonal fluctuations. So there are so many different factors that needs to be considered. And so going through my literature review to try and sum it up and keep it shorter, I think the main things that I do remember and I did memorize, because really we can make the difference with, are the biomechanical aspects, the anatomy considerations, and the fact that we sometimes cannot be at our top form because of the hormonal fluctuations, even if we don't know specifically yet what's leading to potential ACL injuries.
And so you mentioned, one being we're made differently. That's just fact. We are made differently than men. And then the second thing, we move differently. And I want to talk about that perspective a little bit in terms of how much do you think, or when you're doing your literature review, as you're writing this article, and just in your experience in general, how much do you think that the biomechanics are related to how much physical preparation female athletes have compared to male athletes in terms of exposure and access to good strength and conditioning programs throughout their childhood and adolescence and professional lives, the access to resources, the training age of professional female athletes versus male professional athletes in most scenarios. Do you think that that contributes to some of the movement patterns that you're seeing?
So that's a super it's a wide question, and it's very, I think, harder for me just because I don't work specifically in a just club environment. So it's difficult because I have like athletes or female athletes from different disciplines, I would say. So some of them are playing netball, some of them are playing football. So generally multi-directional sports, majority of them. But it's difficult to kind of like have that strict comparison coming from that environment. So that's the one thing I would say. But I was having a chat this morning actually with one of my patients, and she does play football, and she went through 3 ACL injuries. And I was telling her, I have a podcast today, and I'm speaking about ACL injuries. Is there anything from your side that you would like me to mention, or something that you feel it's different from how your males teammates get trained, or how they are approaching the conditioning differently from you? Or is there anything in particular that you want me to say? And the first thing she said is, Vicky, I feel that the problem is that we are just not used to lift weights, and we start way too late. And I was like, this is very interesting, because I know about it because I read about it. And there are lots of researchers that are now considering the cultural and environmental and aspect of the female ACL injuries. But so I know about it. And listening that from an athlete itself, I was like, wow, that's a big thing. So I do think reading and talking to them and kind of gaining experience from different sports background, that there is definitely a huge difference on the conditioning and the access to the facilities and the gym training that these female athletes have compared to males. And talking to a lot of colleagues working on football as well, I feel like a lot of the time now it's getting better, I feel, but a lot of the time they don't have access to as well trained professionals to work with them, because the pay may be much lower in female football, and therefore you don't have as many experienced professionals working there because they would accept a lower salary. So I do think that all of these components that you mentioned are definitely something that are leading to a higher risk potentially of injury, or not having the athletes as prepared to that game situation as they should be when compared to male athletes. Because of that, access to resources is just not the same, for what I'm understanding based on everything I'm reading and the chats I'm having with my patients themselves. So it's something that I feel is getting better, but probably looking at how we are at the moment, there's still a way to go. I don't know what you think about it, working in that, or you worked for a long time, I guess, in the football environment. So I don't know what your thinking is about it, but maybe we can have a chat about it in a different setting. But I'd love to know your opinion on
Yeah.
that too.
Yeah, I mean, basically, kind of what you're saying. Like, yes, there are differences. I think that training age makes a big difference in exposure to good holistic strength and conditioning programs. You know, in the English Premier League, for example, the male professional athletes on the first team, their average age of when they entered a professional club environment, like in the academy system, is like 8 or 9 years old. And on the women's side, the average age of entering a professional environment is like 15, 16.
Wow.
And so that's a big chunk of time of having resources available, like sports psychology, nutrition support, strength and conditioning, sports science, physio, like having all of those resources available to you, and also getting physical exposure and improving physical literacy, right? So the boys from 8 to 16, like that age gap, those 8 years are crucial in physical development. And for the women to not have had the same exposure, generally speaking, obviously there's some who were lucky enough to have that. And of course, there's some male athletes who didn't have that, right? But I think that that's something that we can't overlook for sure. And maybe that if athletes in those peak like physical development years develop a wide enough physical literacy to be able to solve multiple movement problems in multiple different ways, that maybe we see less of a difference in the biomechanics of male versus female athletes. That's just kind of my thoughts on it.
Very, very, very interesting. I think we can go on forever talking about it, and everyone
Yeah,
experiences
definitely.
different and we see different things, but super interesting.
So, staying on the topic of kind of the movement strategies that female athletes typically find themselves in when they tear their ACLs, I know Matt Buckthorpe, Francesco, they've done some studies on like the video analysis of ACL injuries in both men's and women's football. Can you describe some of the most common game situations or movement patterns that typically happen during ACL injuries in women's soccer?
Definitely. So the majority of the injuries in females happen during a defensive or offensive mechanism. So you have generally is pressing, tackling, the most common one. Then you have a landing from a jump or recovering balance after kicking. So these are generally the main ones that you see in females. As we said earlier, a lot of them are non-contact by nature or indirect contact. So that means that they just don't get kicked in the leg directly, or they don't have a direct contact when that's happening. And the majority of them during those oppressive and defensive mechanisms happens in a valgus or dynamic knee valgus kind of pattern, which is something worth to be considered. And I feel like for us physiotherapists, it's so important to understand how does an athlete get injured, what's the nature of that injury, because then we can kind of, with the role of, as Francesco always says, of reverse engineering, is to try and reason backwards and be like, okay, so we know how the injury happened, so what are all the steps in rehabilitation that we need to take to make sure that that does not happen again? So how can we prevent that from re-happening based on what we know it went wrong in that specific athlete? And Ali Keller is doing lots of work on that neurocognitive errors and trying to understand how many things the athlete is thinking about when the injury happens. So what, before that initial contact, when the injury actually happened, about 50 milliseconds from the contact, what is happening before that? Is the ball coming that direction? Is the opponent coming on another direction? Is that another opponent from the front again coming from a different direction? So how many things the athlete is thinking about? So for us, it's super important to look at the mechanism to try and work backwards and be like, okay, let's go and get this prevented, or let's avoid anything else to happen, because we know that 1 in 4 females are at risk of secondary ACL injuries after 2 or 3 years from returning to sport, which is a huge number. So these are the most common mechanism that have been identified, and important to know about it. And sometimes as a physio, I'm like, oh no, I don't need I not necessarily read about read papers about the injury mechanism, because I would prefer to read something about rehab, but actually that's my rehab. so so that's what I feel like.
Yeah, that's such a good point that the how an athlete got their injury, because there's different mechanisms as you said, and knowing how that specific athlete had their injury is actually a great way to individualize their rehab, right? And like you're saying, like I'm in the same boat as you. I'd rather read about rehab because that's what we do. Um, but I do think, like you said, there is an importance of knowing how they did it because that helps your rehab. So, can you tell me a little bit about how you maybe look at how an athlete tore their ACL or sustained their injury and how that maybe influences some of your rehab? Because obviously, no matter what the mechanism was, there's still certain principles we're going to apply. We're still going to try to hit the same objective metrics, but maybe the how we get there is different. So, can you explain how you kind of apply, like, okay, here's how they tore their ACL. Now here's how I might individualize or change their rehab based on that?
Definitely. So I think the main, despite the fact that I feel we can integrate, and again, Ali Keller is doing lots of work on this, but we can integrate that neurocognitive factors from the very early stage of the rehabilitation. I feel that what really makes the difference, and really the understanding the injury mechanism is important, is during the later stages of rehab. So when it comes to me and my personal experience working in the green room, which is our movement analysis room, I I do go back, look at the injury mechanism, speaks to the athlete. The majority of the time, I don't have the videos available, so I need to trust them and understand, get their stories as opposed to actually having read something. And from there, try to try to, in that controlled environment, mm, mm, work on that motor learning to try and make those pattern of movements that lead to the ACL injuries uh, better, in the sense of I will assess the movement, I will make them learning, I will give them the time to learn that specific movement to make it. At one point, it should be automatic for them to move in a certain way. I will teach them how to absorb the shock better. I will teach them how to avoid that valgus knee. I will teach them how they should move with the trunk, with the hips flexion and everything, to the point in which that movement is memorized and is automatic. And when they're going back to sport, so when I know that an injury in an athlete has been no contact injury, I'm already doing and making my kind of like calculations and thinking in my head, thinking, okay, something there wasn't right. That pre-activation mechanism wasn't right. So what can I do in rehab to make sure that they pre-activate everything before they actually land? So I need their body to be in a nice, good position, functional position, biomechanically correct position before that 50 the initial contact and 50 milliseconds, let's say, that the injury could happen again, right? So my thinking is, okay, no contact, change of direction, foot planted, valgus. I'll do everything that I can to just make that correct and automatic in that athlete. So that's my reasoning.
Yeah, and you mentioned Ali Gockler and some of the neurocognitive error processing work that he's doing. And I know this is actually always a topic that's really leaned into at the Isokinetic conference as well, between Dusty Grooms, Francesco, Ali. Like they speak a lot about this, and it's really interesting because I actually just spoke to Wyatt Hempstead, who is, for the podcast, he's doing his PhD in Australia right now, looking at ACL injuries in female athletes and female soccer players specifically. And he recently put out the first paper of his PhD, which looked at timing of the injury. And it lines up with some other like previous work done, but it was a larger data set. And Eve showed even more that these injuries tend to occur in the first part of the game. And so what he was saying was, I think it was like between 15 and 35 minutes, I think, was where he said like the greatest risk is. I have it written down on a piece of paper somewhere, which is what I'm looking for right now. But yeah, somewhere between like 15 and 35 minutes, somewhere around there, that's like the greatest risk of an ACL injury. And what we kind of discussed was along those neurocognitive processing errors, like maybe that has to do with the fact that early in the game is still pretty wide open from like a tactical perspective. And so, yes, you go into a game with your game plan and you know what the coach has prepared you for and how you're going to play against this team. But there's still a lot of reactive things happening, like, oh, they're overloading this side of the field, or I'm seeing space between their center mid and center defender that I can try to play balls into. There's still a lot of like reacting and observing and cognitive processing happen early in the game, whereas later in the game, you're kind of in the flow and the rhythm of it, and it's a little bit more predictable as a player. And so we were like, oh, maybe that has something to do with kind of the neurocognitive processing, that there's so much happening at a cognitive level early in the game that maybe that's part of why these ACL injuries are happening earlier on.
Definitely, that's a super good consideration. Actually, it's true, and the intensity of the game at the beginning is surely higher than later on in the game, is it? So, there are probably, I'm guessing, more things going on at the beginning than at the end. And it's interesting because I was having a chat with Francesco actually, and we were talking about the hamstring injury on the other side, and then lots of things are going on at the beginning of the game, but then fatigue and everything else will catch up at the end of the game. So what is determinant of that injury risk on females, right? So the hamstring injury are higher during the later stage of the game, or later time, let's say, towards the end of it, as opposed to ACL at the beginning. So it's going on. I think it's a conversation that can go on forever and be like, oh yeah, it's speculative, but it's cool conversations to have. I think, because everyone can have their opinion about it, but there's nothing out there to prove it, right? So it's very interesting.
It is. So in the paper that you put out, you went through kind of 7 areas of improvement that we can address in female footballers. And so I'll just kind of read them off right now. The first was tailored prevention programs, staff education, criterion based as opposed to time based rehab, offering psychological support, equal access to facilities and equipment, more research in women, of course, and female athletes, and then individual load management. And so, can you kind of walk us through these 7 areas that you outlined and what you think are maybe like the top most urgent areas to improve on right now?
Sure. So, starting from the beginning, I I forgot the order in which you said them exactly, but I'm just gonna throw and talk to them as a. Um, so surely that targeted rehabilitation or prevention programs, I feel is the most important thing. So I think the feeling I've got is that everything that we're doing is still very generalized. So there may be evidence on what it is, early stage, mid stage, late stage of rehab is criteria based. And I feel that nowadays everyone is kind of reasoning as a criteria based as opposed to time based. I think long time enough we move away from that time based kind of rehabilitation. I haven't heard of that for a long time. So I think that's not happening anymore. But I feel that the programs and the preventions are still very generalized. So I think the most important thing in these kind of like 7 domains I wrote down and recognize in that are stated in evidence, the most important thing is trying to treat the athlete in the most individualized and specific ways as possible. So you want to do your assessment, you do your testing, you do your screening, the movement analysis testing, and I will move definitely different from how you would move to any of my athletes would move. So I think those programs will need either that it is for rehabilitation or it is for prevention. They need to be targeted to how you move, because that is different if you did have, as you said earlier, if you did have access to the facilities earlier in your adolescence years, or if you didn't have access to certain facilities, or if you did work on strength and lifted weight as opposed to if you didn't. So I think we need to be a little bit more specific when it comes to the psychology aspect of it as well. It's super important, but I think, and you probably may agree with me, as a physio, we do consider the psychology of our athlete every single day, every single session. So I understand that monitoring of RSI, IKDC, and scales and questions, but I think that gathering the information on how the athlete is feeling, making them as comfortable as possible in talking to us about all those topics that are stigmatized at the moment. And, even just because if they feel down for the menstrual cycle, if they are afraid that they are not reaching the criteria that we set for that specific stage, or if they feel they're not progressing well, I think as a physio, I feel that psychological aspect is there every single day, every single time. And the most important thing is the communication that we decide to set with our athletes, and that really does make the difference. I was actually reading something very interesting on how females progress on their rehabilitation as opposed to men or males. So the males are much more guided by competing with others to try and achieve their goals. So they're like, oh, actually, I want to be quick on the rehabilitation, I want to reach the criteria, I want to get stronger quicker because my teammates are playing and I need to beat them and then you want to be promoted or whatever they want to do. While the females are much more like, oh, I'm setting my own goals, my own criterias. I trust my physio. Let's work on this together. So it's a lot more relationship based as opposed to actually being as competitive as possible to try and achieve goals. So that's very interesting. So the psychology of how we're dealing with our injuries or how they deal with the injury recovery or prevention is different. So that's definitely something that it's important to consider. And then I think we talked about a little bit. We touched a little bit already earlier on the accessibility of resources and the cultural aspects of it and the environment. We should not be seen as little men, as everyone is saying at the moment. So females are different than men, and things will need to be adapted to a female body as much as we can in line with the available research or evidence that we have at the moment. But at the same time, we cannot be seen differently in the sense that it's if we may feel fatigue in a certain period or time of our month, that doesn't mean that we need to train less. We just need to train differently. So I think that's important. So that's the cultural aspect related to that female being fragile or weaker or different. It doesn't necessarily need to be seen in a with a negative connotation, but just as positive as possible. I think I touched a little bit on everything. Let me know if I'm missing something.
No, that's great. And I think, excuse me, I think that distinction that you made between like, yes, we're different, but different doesn't mean less than. That is like the crux of it, I think, because as things come out in the media, it's like, yes, like women are not small men, we're different. And yes, there are, for some athletes, there's the menstrual cycle might play a large role in how they're feeling, how they're performing, their injury risk. Some athletes, maybe it doesn't affect them quite as much. There's a lot of individual variability there. But regardless, that doesn't mean just because we have a menstrual cycle that we're less than. It's just different. Different is just different. It's not better or worse. And I think that the media gets that wrong sometimes. And it comes out as, oh, females are more likely to have this injury and, they have the menstrual cycle and we're looking into how that affects it. And then it's like, well, that can sometimes be disempowering for female athletes because then it's like, well, I'm just inherently weaker or inherently flawed and not able to do this sport that I love and want to do and without this injury risk. And that's not the right message either. It's just different, and we need to start accounting for those differences and not have the negative connotation attached. So I love that point that you made.
Thank you. Yeah, it's interesting. The same patient, actually, you made me remember now, the same patient I was talking to about this morning. She also said, Vicky, I had experience, obviously third ACL, as I mentioned earlier. And she said, Vicky, I had the experience of my first ACL was misdiagnosed. And I asked her, tell me the story. How was that missed? And she said that the male physio that was assessing her missed the ACL injury because she said that differently from all the other males athletes that got injured, she wasn't reporting as much pain or discomfort. So he was like quite violent, let's say, in terms of like touching her knee and assess it. And then she wasn't reporting any pain. And then he said that he was shocked about years later after the first final diagnosis of ACL injury. He said, I'm very sorry, but I'm not used to see females, I'm not used to see as many females that are not reporting pain, basically. So then she said it's different because males are just generally so kind of like quick and be like, "Ow, that hurts," or So it's a completely different way as well of covering up what we really feel because we're used to have probably a little bit more symptoms than men do. So we just deal with that differently. So it was interesting, kind of like comment that she made, and it's like, okay, good to know.
That's interesting. I love hearing the like patient perspective that you keep like weaving in. That's so interesting to hear what their thoughts and beliefs about it, about their injuries are and injury risk. So going back to kind of the targeted rehab and prevention programs that you talk about in the article, I know you mentioned kind of that reverse engineering philosophy of, okay, this is how they move. Let's break that down. This is how they had their injury. Let's break that down. And now let's address those. Maybe we see like, okay, they're getting to like more of a hip dominant movement strategy instead of knee dominant. Maybe that means we need to work on eccentric quad strength, et cetera, et cetera. Can you talk about your approach to maybe breaking down movement or how you go about specifically targeting and individualizing the rehab and prevention programs for your athletes?
Definitely. So to answer this question, I'm gonna help myself with what we do in Isokinetic in terms of criteria or progression as well, because I think it's gonna be a little bit clearer for the listeners. So as I said a couple of times already, we have access in Isokinetic to what we call the green room, which is the movement analysis room. And Francesco, with the research center in Isokinetic, they developed what we call the movement analysis test, which is a test based mostly on kinetic kinematics. We have vertical ground reaction forces as an assessment, as well as the angles of movement, so knee flexion angle, hip flexion angle, so how the athlete from a quality perspective is moving. And the MAT test, the movement analysis test, is made up of 6 different movements, which are the single leg squat, you have the drop jump, you have the cut maneuver, 90 degrees change of direction, single leg hop for distance, then you have the lateral landing and the deceleration. So I find it quite useful to use those 6 movements as a kind of like a guideline of checking to try and understand how is the athlete movements and move, and is there anything on that movement that is not right? What can we do, and how can I break the task down to make that movement effective and, you know, what we consider good enough before the later stages of rehabilitation, or make that movement a little bit less pre-planned. Which is at the end of the day what the athlete needs to be doing later on. And so let's take for example, I will need to get an athlete having to do a deceleration. And then I realize when I ask them to, you know, stand on one leg, that first of all, they don't have the balance to stand on one leg. Then I'll work on that. And then, you know, I may ask them to do a single leg squat. And then on the single leg squat, I can see that they have a lot of the time, I would say 99.9% of the time, patients having gone through an ACL surgery with an hamstring graft, you can see that knee just completely twisting inward. So you have the tibial adduction, femur external rotation. So you have all the classical valgus presentations. And so I will ask them to, you know, try and do that single leg squat. I will give them a couple of cues, let them learn and process that movement, give them the time to really absorb what they're doing and work towards it. Sometimes I will feel like I will need to go backwards and be like, okay, that medial hamstring is definitely not working functionally, so let's check it out. Is that working when I put it in a very specific, or kind of like in an exercise that's specific for the medial hamstring? So I may ask them to do a bridge with the foot turned in to try and understand whether they're able to target that muscle, if there is any activation going on. If sometimes that's not needed, because I can see that they, in 5 repetitions I ask them to do, they get 1 right. So then I'll give them more time to actually go through the movement and make them learn in that specific movement after a couple of cueing. And so when they have that single leg squat solid, then I will move on into a little bit more teaching them how, for example, to absorb the loading properly. So I may go back in 2 legs and be like, okay, let's try and see what shock absorption means. How can you make that eccentric control smooth? How can you actually make it work? So then I'll go into single leg. I'll ask them to go, for example, into a very quick eccentric squat to try and make that feeling right, or make them feeling that specific move to make them familiarize themselves with that specific movement. And then I will go into 1 leg, and then I may just make them skipping on the spot, make sure they're confident with the skipping on the spot, and then ask them to do a little deceleration and see whether they're able to actually absorb that loading into 1 leg. If they're able to do it, then I will move the distance and ask them to start further away from the actual deceleration spot. So then I will increase the task demand to the point in which it is still a pre-planned deceleration, but the intensity of it goes up. And that's how I will work and break down every single task that we think in Isokinetic are the necessary tasks for assessing the movement quality of that specific athlete before the on-field rehabilitation. Sorry, that was like a long answer, but I think I was trying to give as many clinical...
No, that's perfect. Yeah, that's perfect. And how often are you bringing athletes into the green room during their rehab?
All the time. So if an athlete is compliant with the rehabilitation, we always want them to go through the green room, especially if it's an ACL injury. We know the importance of that neuromuscular training in ACLs, and so for us is number 1 priority. It's probably, I always say to my athletes, some of them are semi-professional athletes and they may not have the same availability financially that, you know, professional athletes may have. And so sometimes I tell them, listen, I just much rather you do your strength training by yourself. So I'll give them specific, very detailed program where they just have to go to the gym and just kill themselves with different type of loading and so on. obviously making sure that the basics are already being reached, so extension, range of motion, there's no swelling and so on. And then I tell them, if you have money to invest, I want them to invest in the later stages of rehab. So I need your neuromuscular training to be done. I need that specific pre-planned movement retraining to be done before you're going on the on-field, or even worse, to the team play, to the team training. Because a lot of the time I find when you don't have that access, you will just skip very important parts of the rehabilitation, and we just all know that that's never gonna work. So if you're missing just one component, you get into the, even if you wait 12 months, everyone is talking about, it's just not enough if you're not doing every single thing that you're supposed to do with it. So we try to make everyone going through the green room as much as we possibly can.
And are they going in the green room like almost every session that they're in there with you, or at certain time points to kind of just check off if they're moving efficiently? How often does each athlete go through it within their programs?
So when we see the athletes generally at the beginning, they are obviously post-operative. So we have all the early stage that will happen in between the pool and the gym. So we generally see, it depends from the level of the athletes. And as I said, the availability, financial availability, but normally we see them a minimum of 3 to 4 times a week for between 3 to 4 hours. So it's very long rehab sessions where we try to cover as much as we can. And then when we reach the criteria to go from the early stage to the mid stage, Matthew Becktorp has done great papers about it, and we tend to progress them towards the gym and the green room. So that is the time where the majority of the sessions will happen between the gym and the green room. So lots of the time, let's say that on average, you see an athlete 3 to 4 times a week, as we said, you may have 2 sessions in the green room, 2 sessions in the gym. So that is the time where they're still recovering the final strength. So they may still have a limb symmetry index of 80%, so still 20% lacking, but it is the time where they can already start working on that neuromuscular control, neuromuscular training. So then you will progress them into the green room while still holding them back a little bit to try and gain back the missing strength. And that whenever the late mid-stage criteria are reached, that is the time where you would progress the player out in the pitch. And sometimes it still happens that some of the most complex pre-planned movements are still not gained or still not perfect as we would consider perfect, which we think it would increase the risk of secondary injury. Then we will keep the player from the green, in between the green room and the on pitch, on the on field. So then it's kind of like a progression a little bit here and there to try and fill up the gaps, but at the same time don't hold the athletes back, because there is still lots of components that needs to be filled, really. So that's how we work. And the more the player can come, obviously the better, because that will make everything not just quicker, but easier, I would say, for us, because we have a continuation and we just don't know what the athletes do when they're not in rehab. So sometimes that's something that needs to be considered as well.
And that's another great way of individualizing the rehab is it's not just, okay, you're in this phase, now you're in this phase. It's, well, you're able to do this from the next phase, but you're still needing this from this earlier phase, and just kind of like dialing up and down where needed, or like, turning the dial up in one area, but maybe turning it down or keeping it the same in another. That's another great way of individualizing and having a targeted rehab approach for each athlete. So Vittoria, I am so appreciative of your time and you coming on this podcast. I think that there are so many great clinical pearls in the discussion that you've shared with us so far, but I can't let you go without asking you my 2 rapid fire questions that I ask every guest. They're more fill in the blanks and they're all just your opinion, so no pressure.
Okay.
So the first question, or fill in the blank, is I wish everyone working with female ACL injuries knew this about rehab and prevention.
Knew. That's tough, actually. That's the hardest question I have to answer. Knew more how female athletes move differently from males. What are the recurrent patterns that female athletes present with? That's the most important thing, I think. So if you knew what you're looking for, it would be so much easier to treat them or to prevent injuries happening to them, I think.
Okay. And again, that's another great way to individualize, like we talked about. And then the second one is my favorite thing about working with female footballers is.
They are very open and they trust you fully. If you do give them your knowledge and if you're very transparent with them, they just give you their all. And that's amazing for me. It's just the most amazing thing. And when they come back and they're playing and they invite you to a game, it's just the most rewarding thing in the world. So I would say how open and trustful they are of you and your work. So that's the main thing.
That's such a great point, that as long as you show them that you're knowledgeable and that you care and that you share with them the information and are, like you're saying, transparent with them, that they buy in. They are all in on it. That's such a good point. I love that. Well, Vittoria, thank you so much. And if people want to follow you and continue learning from you, where should they go?
So they can go on LinkedIn. My name is Vittoria Marin, Marin, or Instagram, Vicky Physio, and that's pretty much it. Oh, my email, b.marin@isokinetic.com.
Okay, thank you so much. I really appreciate it.